I can go to the office visits. I can help provide you with alternatives, or where do you go for clinical trials?
Introduce yourself. Maybe say a little bit about your background and your business and your mission. So tell me, who are you and a little bit about yourself.
So my name is Cheryl Ringo.
Okay.
I am a registered nurse. I was in the hospital for 19 years, mostly with a focus on the emergency room. I was trauma trained back in 2003. I'm originally from Pennsylvania, so I started at a large hospital, trauma hospital out there, and then decided to travel. That's how I, through travel nursing, came out to California.
Wow. Okay. So you were a travel nurse during COVID times, huh?
Before.
Okay.
Before, there was a period, 2006 to 2014.
Okay.
I did it for a while.
Wow.
And then I came out here and started to work in California and took a staff position and bought a house and started to put down some roots.
Okay.
Yeah.
And you decided to put down roots in California.
Yes, I did. Northern California.
Yeah. Good.
So just a lot of ER experience, some ICU experience. And then I think the biggest thing has been the case manager experience.
So then you decided to put roots down in California. And
Yeah, I did.
okay.
And then, so I got a bit burnt out on the hospital. And COVID was a part of that. I think just the stress of it, policies changing daily, being on the front lines. I think it was just became, after about 19 years, it was one of those things that I got through. And then I think my time as it was about done.
What was the hardest part of COVID was it staff calling off? Was it you guys were understaffed and just the overwhelming people?
All of it.
Or
Probably just all of it.
Yeah. I remember going to the emergency with my daughter during that time, and every room was filled in the ER. And then there were like chairs outside of the hallway and just people sitting. And I was like, no, we're just going to go take care of this at home.
Yeah. I think it was just accumulation of everything that just.
Yeah.
Yeah.
And then you decided to venture out on your own.
I left. I felt like it was burnout. And I just so I've explained this previously. I've explained this to someone that when I got into trauma and I got into the emergency room, it was about the trauma and the drama and the blood, and you wanted to jump into the excitement. And then I think you continue to build with your experience and you continue learning, but then it becomes, why is this not getting done? I think it's the critical thinking piece that you begin to develop. And then when you have other people that maybe are order followers and that are just doing things without the why.
Yeah.
And then you're like, this person can't go home. We didn't do X. Like, this would not be a proper discharge, not just because the doctor says so, but we have to know why we're doing something. So I feel like my experience, just having been there that long, I think it probably was just doing too much. And then it just was like, this is just not a good fit for me anymore.
Yes, totally understand. And you know what? Let's talk a little bit about improper discharge and falls with the elderly. You talk a little bit about what in your career experience that you have seen improper discharge or like the repeat offender, like they're bringing Miss Sally back and this is her third time. Nobody's there taking care of her. Let's talk about that.
I listened to actually a podcast on the way in here to prepare.
Perfect.
But a term that was used was, hang on. Sorry. A term that was used was volume over value.
Okay.
And it is ERs and hospitals and doctors, it's volume based. It's not about giving value. So when somebody comes in, it's not you're looking in the emergency room just at the fall.
Yeah.
You're not looking at who they're getting discharged to or where they're going, what type of support. That's more comprehensive. Because I had ICU experience, I think that's maybe what made me a little bit more well-rounded with the family and a more comprehensive view.
Yeah.
But most people who've been born and raised in that ER setting, it's that algorithm. So if you're there for chest pain, abdominal pain, a fall, it's like, that's what you get. And then you go on your way. But it's not taking a deeper dive into what's going on. And then, yes, specifically with seniors, if they don't have anyone to advocate for them, they don't know how to advocate for themselves. It's okay, we've done X, they're ready to go.
Yeah.
But go where?
Yeah.
Go back to the home where they're going to fall again, maybe where medications are a reason for their fall, because there's different reasons for falls, whether it's mobility issues because of weakness, or is it because of polypharmacy? And people go from the hospital, they go home, they go to skilled nursing, home, or there's any time that there is a change in their location, there is a possibility or probability of error.
Yeah.
And then you have brand names, generic names, and things can get, people don't know that I should stop this. And this is a generic name and I was on the brand name and they didn't have this on formulary. So it's very overwhelming.
Yeah.
It's for people, for their families that are not medical.
Yeah. And let's talk about the gentleman that I sent your way. This is a perfect example of the right hand doesn't know what the left hand is doing. And then you send them back to their community and nobody's there to support that transfer without using their names.
Right.
But had a client in memory care. Everything was going fairly well.
Right.
She took a fall and hospital, skilled nursing facility, and then they prescribed her a new medication.
Yeah.
That and the modality was not supported by that community. Most communities, unless they have a nurse on staff 16, 18 hours or more, they're not going to do any injections. They just won't. They won't. It's a Title 22 regulation. Maybe there's a few communities that will do some sliding scale, this and that. But if not, you have to find a different delivery route or stay longer in the skilled nursing facility. And they sent her back. And let's talk about that conversation with that son, how
that the hospital prescribed a blood thinner injectable Lovenox.
Yeah.
And through my conversation with him, she was already on Plavix and aspirin. I want to say that I'm a nurse advocate and hopefully board certified because I did sit for those last weekend. But as a nurse concierge that would be able to go in and deliver that injectable, right, on a short-term scale, I can't even recommend, I couldn't even refer you to someone because it's hugely contraindicated and that she would be so hyper coagulable, like her risk for bleeding, either spontaneous or if she fell. I can't take that assumption of risk. But what I can do is let me call the doctor.
Yeah.
Let's have a conversation. And he said that they knew. Regardless, let me do that. Let me make that phone call. And that's how I can act on people's behalf, is sitting with them, looking at their medications, looking at their goals. This is not what a primary doctor does. It's not what the ER does. And something else I listened to today was that nothing, like 90% of people, no one focuses on prevention.
Thank you. Isn't that, yes.
Everything is reactive and we live in a reactive society. So it's like we have to wait for something to happen and then we deal with it. And I think that having a nurse advocate or an advocate in place, but having somebody there with you, I know that for me, if I take a history and I take just everything I think just my skills from being in the hospital, right? So I'm going over your medical history, your surgical history, who your family is, what your allergies are, but also what are your goals?
Yeah.
And I don't think the doctor doesn't say that. Yeah. The doctor doesn't go in there
or even step into the home. Coming into one of the older adults' home and you see what's going on and, this is a hoarding situation, or you have a dog that you really can't take care of, or you got that sunken in living room and this is no longer a suitable environment for you.
Right.
You know, it's such a different experience. And then I will also get families that they're like, my mom, she doesn't want to go. She doesn't want to go anywhere. She doesn't want anyone in her house. So they allow their aging parent who clearly needs help to stay home and make some bad decisions.
And I think that brings up a couple of different topics too, is are they capable of making those decisions?
Yeah.
Or would they be more open to having a conversation with a third party as to why when someone tells me, just let me die, because I've had that happen. And then I have the daughters that say, oh, she's been married 3 times. It's okay, mom. Perhaps having a mediator in that space to say, this is what we're looking at and give a full picture. I think it's important to honor someone's wishes, especially our elderly, as far as what they want to age in the home or whatever their goals are. It's fine. I feel like it's fine to have whatever goals you want to have. If you want to sit there and let things happen naturally, like if this is the way the Lord's going to take me, then so be it. But if you say, so I have a client right now who said she wanted to be in her house the next 10 or 15 years. So that's where she wants to age. And the way that she's utilized me and the relationship that we've created is that I call her weekly. That's our dynamic and what I have for her. And through that, when I say, how are you feeling today? How is everything going? I know her stressors. And when she says things like, oh, I was a little dizzy, and I know that there's no reason for her to be dizzy. And there's a couple of things that pop up that are red flaggy for me. So then I say, if you want to, we have to have a conversation. So if you want to be in your house and you want to be proactive in your care, then these are some of the things I think we should look at. And specifically in that case, I got her, changed her primary with her, of course, with her approval, because there, again, we're not looking at prevention. We're looking at, how are you doing? So is everything okay? Because you're going in for your yearly, or let's just order that blood work and we'll have you come back to go over it. But where's the prevention piece? So I think with being able to establish that relationship, being able to know what her goals are, then we can talk about the preventative piece. So when I know that her being dizzy is not normal. And then I say, your doctor, she goes, oh, she had me checking my blood pressure twice a day, but they've changed my appointment twice. Like, it's not reasonable. We have seniors out there that need care. So let me get you into someone else. So then when I got her into someone else, and then we talked about some of the issues that she was having, then it was like, oh, let's get her into neurology. Let's get her into cardiology. So right now we went to the cardiologist, and she ends up that she has a blockage of one of her carotid vessels.
And so you pushed the primary to make these referrals.
Yes. And I would say, if I would say, then I would, when we talk about advocacy, because there's different types, there's advocates that are nurses, and there's advocates that advocate that they will go to a doctor's appointment, like for family, like they will go, and maybe they have a social work background, or they did something corporate and they know how the system works. Now, but having a nurse is how do you pair that chief complaint, or what is it about their complaint, how do I pair that DRG? Because everything has to have a code. It's, if you want me to do a CT of the head, then maybe I need to talk, okay, it's the dizziness. Like, how do we
have that conversation?
How do we get that role? I'm there to communicate, but also I already prep my client on what we're talking about, what our goals are for that appointment. So I've prepped them. And then when we go in there, I have that list. So when he says X, Y, and Z, or I'm saying, we didn't talk about a colon screen. That's been 5 years. Why has a 75-year-old not had a colon screen, not had a CAT scan, not had a stress test, not seen cardiovascular? There are preventative things that aren't getting done. No one's having those conversations that there are. And so there's things that you can do.
For the hospital, they just don't, is it the insurance?
Volume. Oh. It's volume. The more volume they see, the more money they can make.
So they just want you in and out.
It's a turn and burn. So unless you sit with them. Okay, so I had another client not a client, but someone I spoke to who had chest pain, middle-aged man. And he had been hit with something. But again, you don't know. Was that the cause of it, or could there be something cardiovascular going on? So he said he went to the doctor. He went to the emergency department. Sounds like they did a very thorough job. But as I talked to him, I'm like, there was sudden death in his family. No one's having that conversation. So unless there's no time. It's not the space. The emergency room is to look and see and define, is there something here that needs care right now?
The chief complaint, the broken ankle, the one thing.
That's it. everything out that's like for someone else.
Yeah. Go see your primary. Good luck.
So that's where I came in and I said, because of there's been like sudden death, I would think that you should see a cardiologist. You should have a stress test. You should have a calcium score. You should have these things. And then I don't know what ended up happening with that, but I called too and I said, oh, I called so and when they're taking new clients and this is the number. And then you can only do so much. But people have to find value in this. They have to want to be proactive in their care.
Yeah.
But I think there's services out there. I think that there are more advocates coming into this healthcare realm. I think healthcare is definitely changing. It's changing. Insurance and all that is changing, but the number of seniors that are aging every day are by the thousands. It's like, I don't know. I think it was 16,000 a day, but I think it probably is more than that.
Yeah.
That are turning the age 65 and older, and they're going to need help. They're going to need us and all of the senior people that are out there to support them.
Yeah. And oftentimes the adult daughters won't find out about anything until the major catastrophic event has already happened.
Right.
And then they're like, wait, hold on. I was looking in my mom's health records and we could have intervened here. So let's talk a little bit about when you are brought in to help an older adult prepare for those doctor's appointments, because I think that is so important and such a missing link. Even if you do move to assisted living, no one's kind of has their arms wrapped around you. And
no. But I think another part of that is what I find too with seniors is there's this, it's this like dysfunction. Like you learn how to live this way. Now, if someone was to drop you like the crab in the hot pot, if we're going to put a crab in boiling water, that thing's going to be out of there. But if you're going to slowly increase the temperature, it's going to sit in there for a while and be like, this is a little uncomfortable.
Yeah.
And then it comes to a rolling boil. And I think that's what happens with people. And then especially seniors, right?
Yeah.
It's like they live with chronic pain. They have issues that they've learned to live with it. And I think that when it comes to falls, if they wake up a little dizzy, I don't know. Okay, maybe I'm a little congested. Maybe and then it's a very different generation that we're dealing with too, that maybe they didn't run to the doctor for everything, or it'll give it enough time. It'll work itself out. But that's where, when I talk about fall prevention, things like knee pain, ankle pain, things that you may have been living with can actually be your risk for fall, but you've just dealt with it.
Yeah.
People deal with being unable to get out of a chair, and that's their norm. It's how they live. Our view, I think, as people, our perception when we are looking at the world, it's so different than what people see of us and how we decompensate and how we're not the same. And so I think they just keep going, not seeing this side of it, of this isn't okay.
Yeah.
Because I did a talk a month or two ago, and the one gentleman had said he's falling every other day and he couldn't wait to get out of there.
Wow.
And so sometimes you can't, that's their norm. It's just, I fall, I get up.
Yeah.
But why are you falling? And I think with that is that there are devastating effects to falls, especially unassisted falls. Like if you don't have a grab bar.
Yeah.
Because if you have something to grab onto that you had already put in place, then the devastation of the fall is less versus I fell, I hit my head, I broke my hip.
Yeah.
Broken hips and brain bleeds are huge. If you have a skin tear or something like that, or a broken wrist, you're lucky, but they just fall over.
Yeah.
And if they're on a blood thinner, they're probably outcomes just aren't great. And it might be an immediate not great, or it's now they need surgery. Now they need skilled nursing. And a lot of the times morbidity, mortality, like the outcomes for a senior, they just don't do well about a year and a half down the road. And if they fell once, they're going to fall again. It's just poor.
Yeah.
Versus let's look how you move. Let's get the proper DME. Yeah. Let's put in the handrails or whatever it is that you need.
And get rid of those damn throw rugs.
Let's get, but you have to want that.
Yeah.
You have to want to say, because once you fall and if you really hurt yourself, then your say is gone.
Yeah.
it's gone. And I feel like that's pretty tragic. I think I did a advertorial in Brentwood Press in February last year, or this year, early in this year. And it was about falls, because we protect our children and we do nothing for the elderly.
Yeah.
There's nothing in place. Everybody will look at the kids and what needs to get done to protect them. Why do we not have that same value on our seniors? And it's just hurtful.
Yeah, for sure.
Because it's preventable.
Exactly.
It's preventable. And as an ER nurse, and it never mattered where I worked.
Yeah.
Right. As a travel nurse, I was in Texas, I was in Maryland, I was here, I was Southern California, I was different places. And it never really mattered. Like in the emergency room, you're going to have broken hips all the time.
Yeah.
And older people. And you're like, gosh, no one's put this in place. I think that's.
Yeah. I would say easily 90% of the clients that come my way are a result from a fall.
Right.
So, and then it's okay, dad can't stay home anymore. We have to look at some alternative options because we can't afford the 24/7 in-home care at, $45 an hour.
But look at this, not only the financial burden, but the burden on the family to even just their concern for their parent that they may fall. I talked to someone recently that she knows what I do very well. And she has a mom that stays with her.
Mm-hmm.
And I said, it's not if, it's when.
Yeah.
It's when.
Yeah.
And then she says, I don't think she's going to want to make any changes. But I think if people knew like how that looks once you fall and the loss of control.
Yep.
I wish they saw that piece.
Yeah.
That they would be like, okay, maybe I need to not be so hard-headed or open to being more focused on prevention now.
Yeah.
Than letting things happen and then trying to figure it out. But
yeah.
Especially during
this holiday seasons are upon us, right? As soon as all of the adult children, they'll most likely go home for the holidays. Mm-hmm. And I always tell them, I want you to check like the garage door. Does it look like it's been ran into?
Does that happen?
They're like, no, my dad's fine. He's living independently. And I'm like, while you're there, just check for some expired food, some mail piling up. Mm-hmm. Check that garage door. Has it been rattled too many times? And that's a telltale sign that some things are changing and maybe you should step in and start having some conversations. How do you facilitate some of those difficult conversations with families?
I think it's getting to know the person first.
Yeah.
You have.
So the senior, you're getting to know the senior first.
Yeah.
Yeah. Because nobody wants to be told what to do by their kids, right?
No.
Yeah.
I think it's maybe lack of there's different motivations with family, whether it's.
Which is interesting because we come in during that last 3 to 5 years. So we get to see what that relationship dynamic was and whether someone's hell with mom, she sink or float, or I want to do everything and micromanage everything. I want to know that she's had a BM today. I want to know everything.
Yeah, they have different. What's the word that I want to use? Oh, we can cut that.
Yeah, we'll cut that. But
what's the word?
Motivating factors.
Like motivations.
Yeah.
They have different motivations. Because I see that now too, like why there's someone with a family. I got called for somebody and she's 98, high 90s. But why is the motivation of the family there? And is it for the best interest of that person?
Yeah.
Or are you just waiting until, because of financial outcomes or what have you? Regardless, I feel like they should be protected.
Yeah.
And as long as they can communicate with me and I understand and it seems reasonable of what they want, then communicating that with a family or having a family conference or just calling that. Yeah. But there's history. When you say you're coming in the last 3 to 5 years, these people are around 70, 80, 90 years and then their family. So there's this whole history or these family dynamics and this whole spectrum now of what are we walking into and how do you best help?
Yeah.
How are you going to be most effective? And maybe you can't. Sometimes you can't help everybody.
I know. You know what? This last week I had a client who maybe she had some mild cognitive impairment, but she definitely had some mobility issues and she was already hunched over and her daughter was spent mentally, emotionally. She was done taking care of mom. She had moved from Arizona to take care of her and she was just done. And she's, no, I don't want to do this anymore. My mom wants to stay home. She can't afford to stay home. I did the best that I could to consult with them, spoke with her, and she was like adamant. She was digging her heels in the ground. I'm going to stay home no matter what. I don't care what these kids have to say. I'm like, hey, I respect it. Well, let me just exit stage left. The kids said, okay, Mom, you want to stay home by yourself? And then they left her. They left her for a couple of days for her on her own devices. And I was like, oh, that's a bold move. That's a bold move. But she managed by herself. And then after the third day, she said, okay, I'm ready. I can't live alone.
But we can put things in place.
Yeah.
We can put things in place, whether it's home care. I think that's one of the things as I've been building my business this past year is the networking and finding people like yourself. And there's a couple of, not a couple, there's a robust network that I now have of people that I can call on. So when you say, hey, talk to this person, then I can say, I don't know that I don't do that, but let me get you someone that can.
Yeah.
So it's just networking. So how do we provide them with this information and the resources that they need?
Yep. Which is so important. And I think if her daughter had less of the management responsibilities of everything that goes into managing mom, she could go back to being her daughter and not.
That's a whole separate conversation because now it's you want to be the daughter, but you're the caretaker. Can I talk about my dad?
Yes, absolutely. Yeah.
That's how the nurse in the family really came to fruition, I think, for the first time for me with my dad, because I was going out for Christmas. It was 2019 and I was supposed to go visit my mom and dad back in Pennsylvania. And then he ended up being in the hospital. So it was not, I didn't expect it. Okay. So I was like, okay, I'm going. So he lasted for 3 weeks. Yeah. He ended up with a cancer diagnosis. So it ended up with a pneumonia. And then it turned into, no, hold on, we found cancer cells. And so as his daughter, but as the nurse daughter.
Yeah.
After everything was done, I was like, who would have done this for him? Mm. And his experience would have been completely different.
For sure.
Because if I wasn't there, he would have sat every day and just decompensated more. And that he would have just been at the mercy of the hospital, right? Or the social work. And they're just doing their jobs, right? Everyone is here. We all got here because of passion, right?
Yeah.
But again, it's volume. It's not the value piece. So now he's sitting there. And he wouldn't have been able to go home. He would have went to Manor Care and then I don't know what would have really happened.
Someone who knows,
when he passed, I guess they would have asked him who his mortuary was.
Yeah.
And now having me there, I brought him coffee every morning.
Yep.
I made sure his bed was changed or I can change it, or I was there during the day. So if the doctors came in, I could tell when he was getting tired and he was getting frustrated. It's a lot for me versus now you're elderly and now you're sick.
Yeah.
Which just confounds everything, right?
Yeah.
When he got tired, I was like, do you want me to take over? And then the doctors change.
Yeah. Yeah.
And now you have multiple disciplines.
Yep.
It's exhausting. But when it was time to have those conversations, if he didn't want to talk, I talked.
Yep.
I'll deal with it. I know what you want. Let's talk about it.
Yeah.
I was able to get him home. I got his apartment ready for that.
Yeah.
For him to come home.
Yep.
And then I was able to meet hospice there and made sure he had the proper DME.
Yep.
Which that fails so much.
I know.
A lot of times you'll get people in the ER where the oxygen wasn't delivered before the client.
Yeah.
Or what else? It just, DME, it's never failed.
Yeah.
That the person will go home beforehand. Just getting that in place and then being able to, what do you want? Do you want pizza? Do you want ice cream? What do you want? And then I think the most important part of that was, what do you want me to do for the end?
Yeah.
And what do you want that to look like? And for him, it was just make sure I'm comfortable. Mm-hmm. And then it was what he wanted me to do with his remains and how he wanted that to go. But who would have honored that?
Yeah.
And for those people that are aging, for solo agers, I think it's so important because as an advocate and as a nurse advocate, it's not just advocating for the things that should be done preventatively, but just that people are going to do what you ask them to when you can't talk. I just lost my train of thought.
To do what they ask you to execute
my over 40. I just forgot what I was saying.
I know.
But it's the oh no, I just forgot.
Honoring their last wishes.
Yeah.
Honoring
But I
their
just
last wishes when they
totally
cannot
just
communicate anymore.
But it's true.
Yeah.
But it was how I did the ashes and stuff more my dad. Nobody else would have done that. But it wasn't about what I wanted or what I thought was best. It's what he asked for me to do.
Yeah.
And I think that having had an advocate, I think I would have used an advocate. So I could have been the daughter that I would have had a relationship with someone in addition, to bring into the circle that they could have done that.
Yeah.
Because it's not about money, at least with my dad and stuff. I wanted it to be about how the end looked for him.
Yep.
When I feel like that's honorable, especially at the end too.
Oh, for sure.
How do you pay homage to somebody but I didn't get to be the daughter in that, not until after everything. And one of the things that he did, which I think is spectacular, is that everything was in a binder. Everything that you need to know is here. And there was open communication. And I think a lot of times too, that's a whole other situation, is that seniors don't, again, it's everyone, right? Yeah. Because there's this stigma. If I talk about death, I'm going to die.
Oh, I'm lined up. I'm dialed in. Probably the only thing I don't have in my little trust binder and everything is my passwords, because they change so often. My passwords. My husband, on the other hand, he's got an app with a vault with passwords and can assign a legacy person. Me, I not so much.
I have everybody dialed in too. Yeah, because you just don't know.
Yeah.
But with the senior people, you have to, there's so much with whether it's your advance directive, your estate or trust, you have to make sure that paperwork is done and
and you're having those conversations and pointing them, saying, hey, this is a good attorney. Here's a fiduciary.
I have tons of resources to share with them or to put, because it's comprehensive.
Yeah.
These are things that I'm not good at. I'm not going to know, but I can find you someone who can, because this is a piece of the pie, right? It's when you talk about, like, again, solo aging or just agers in general, it's comprehensive. There's many different offsets of things that, whether who is there to support them if it's not their kids and their community. What kind of ties do you have? It's not just the paperwork. Yeah. It's taking a full comprehensive view of everything. But yeah, I think that my dad was what started when I walked out of the hospital. I think it was the hospital. And I was like, wow. I'm so, like I said before, he was like my best patient because for 20 years or 17 years at that point, I was like working as a nurse, but he was my favorite one because I got to show him like smart little whippersnapper kind of thing. Like for him to be proud, like in that last the moments that we had, but it was just honorable to be able to, like I said, take myself out of it. And I'm going to do this for my dad. Yeah. Because this is when he can't make those decisions, it's honoring what he wanted. And I feel like it's such a beautiful gift to give somebody and support them through that. Yeah. But that's how that all kind of
know when to call in the professionals. I took care of my grandparents and he was on dialysis. My grandfather was on dialysis probably a little bit over a year, but at one juncture, he was just done. Yeah. And one day he woke up and he said,
and that's okay too.
I'm not going today. And I said, what? Because I would take them 3 days a week. And my grandmother had Alzheimer's, so I would take her over to the day program. Then we'd go to dialysis, and I'd just sit there and doom scroll in there in the dialysis center with him. And I stayed with him during his dialysis treatments because there was like one doctor, a couple of nurses, and like 20 chairs. Just people running. So if I wanted to be there, if he needed something or he was getting a cramp, and I could be like, I could be that person, right?
Right.
And then
an advocate.
Yeah.
Again.
Yes, yeah.
Yeah. But you did that unofficially, or what?
Yes, I did that unofficially. Yeah. I wouldn't do that as a profession because it is taxing.
It is taxing.
Yeah, it is taxing. You have to be a certain person that has that.
You have to know
bandwidth.
But you have to know your why. Like not everything is calling on medical people that are trying to do their jobs, and not everything is emergent.
Yes.
So you have to know why you want things a specific way.
Yes.
Or the reasoning behind it. So going back to the lady that I'm helping when I took her to the cardiologist, again, it's volume, right? Yeah. So the cardiologist comes in and we're going to start this medication, which was lisinopril. And then we're going to start, it's called, I think, Repatha, which is like a new medication that's on the market for people who can't tolerate.
Isn't the lisinopril really hard on the kidneys?
I believe it could be,
because my grandfather was taking that. And then I remember, this is how we found out that he was in renal failure. Let me tell you how crazy this is.
Okay.
We go to the doctor. So for years, I'm not going to the doctors with my grandparents, right? But when the grandmother had Alzheimer's and she couldn't be left alone in the waiting room, she'd wander off, then I had to step up to the plate and I'd go to the doctors with them. I'm in the doctors with them right here in Contra Costa, and I'm with grandma, but we're going for her care because she's all that matters, because he's primary caregiver. He's not taking care of himself. No problem.
Right.
Dr. Kremen says, "Oh, Francis, your granddaughter's here with your wife. Why don't you go down and get some blood too? Because we haven't done anything with you for quite some time."
Ooh.
So I'm like, "Yeah, okay, I got grandma, no problem." He goes, gets his blood work done. That night, we get a call from Dr. Kremen's office. "You guys need to get to the emergency right now.
Oh, wow.
You're in renal failure. I don't even know how you're operating right now."
Mm-hmm.
We went straight to the emergency and he was admitted and he had to get a port.
Mm-hmm.
And I was like, so here I was thrust into overnight primary caregiver for my grandmother. I quit my job, started taking care of her, because now we were doing this whole hospital dialysis thing. And I was like, wow.
Yeah.
Can you imagine if Dr. Kremen would have never said that day, "Hey, you have support, go get your blood work done"? We would have never known.
Very good on his part to be proactive and say that. Yeah.
Yeah.
Yeah. Doctors don't.
Yeah. You would think some system, and we have so many technologies that would call automatically, auto dial someone. "Hey, guess what? Your labs are due, or why don't you come in for a mini mental, or you're 81 now."
There's no, so even when someone, it's funny, it's not funny, right? But sorry, it's not funny. It's actually quite sad. So even when it comes to long-term care, and for those that are listening to long-term care, this is my soapbox. It is reactive.
Yeah.
You will pay to put someone in the home after they fall.
Yeah.
After there was an incident. Now they need home health. Now they need assistance bathing. But you will not put an advocate in place to look at the home, to make sure that they don't fall, to look at the meds, to do anything huge.
Yeah.
And I think that because that's been one of the things on my mind, like, how do I go about having those conversations with these long-term care insurance providers? There's Genworth and all of these providers out there that and they're all the same.
Yeah. Yeah. I know. Oh,
I don't know if I should say all that, but you know what I'm saying? Like, if the ones that I know of,
yep.
It's you're being met with the same. It's the reactivity. Now that you have this policy that you got in place 40 years ago, and now that you want to use it, but if you have a cognitive issue, if you have a hearing deficit, visual deficit, if you are a little anxious driving now because you just don't feel comfortable, they won't pay for someone to go pick you up. They won't pay for someone to make sure you get there safely and that someone's there on your behalf and making sure that you're okay. They won't do that, but they'll pay after you fall.
Yeah. Yeah.
After you were hospital.
Yeah.
So it's,
once you need 3 or 4 of the ADL supports, then we'll help you. Then maybe that claim might get processed, but let's see what our waiting period is like. And even if you last,
but it's what you paid into for years.
I think we only used, so we had CalPERS long-term care, maybe, and he had been paying into it for decades. Okay, decades. He could have invested that money in something else, but it's neither here nor there. We maybe used that whole entire thing for 18 months. That's it. And I was just...
You're almost better not using long-term care and then putting just an investment on the side that will, here's 10% or whatever on your return, and put money in there.
Yes.
And
so that's funny that you say that. As soon as I turned 40...
Like an IRA or one of those, you just like a 401k, just something that this is my contribution.
Yes.
And
my long-term
care. But you also have access to it.
Yeah.
When you need it.
Yeah.
If you need it earlier. Like
exactly. Or if you need that fancy chair lift, that whatever, remodel a bathroom, right? You have access to it. That as soon as I turned 40, that's exactly what we did. We consulted with a long-term care insurance guy, and we went over a bunch of policies and what it would have cost us. It was going to be like $900 a month. And then we just started doing the math.
If you put $900 away on your own and you put it into something that pays you X percentage, what is your return on investment and compound interest? I'll tell you.
Exactly. So that's exactly what we opted to do then, to do the long-term care insurance. My goal is to just all about prevention as well, take care of myself so my kids don't have to take care of me.
Yes.
That's the idea. So
because it shouldn't be a caregiver strain. It shouldn't when you have kids, I just don't know that seniors know that this advocacy is out there and how much support is really in our community for them.
Yeah.
I think, like I said, it's blinders. It's the day to day. It's like they get up and make your coffee and sit and read your paper and sit in front of the TV, and you just continue to decline on the back end. But you're not saying, is my trust, is my will up to date? Is my pulse up to date? Have I had these crucial conversations with my family about if I fall? No.
Yeah.
But now you have someone come in and then you form a relationship or connection because it's very personal.
Yeah.
I don't take this lightly. They're good connections with people.
Yeah.
Genuinely. So, yeah.
So tell me a little bit about the conference that you went to. Let's talk about the conference.
The Healthcare Advocate Summit. That was in Las Vegas. It looks like, so this is, I believe, their third year.
Wow. Okay.
They had it twice before, and I believe that it will be at Caesars the next 3 years. They had a contract, I believe, for that. So it's the first week of September. But it was, again, just healthcare focused, staying on top of what changes are, whether it was with insurance. Pharmacies came to talk about their latest and greatest. And I think it was just knowledge sharing, partnering with other individuals, meeting other advocates. And just, I think for the advocates that are out there, that they created a space now that we can meet and we can discuss and we can, again, just add people to our network. Like, these are the things that I'm going through. And how do I best, if I've never written an appeal, but now I know people who do, or they had these guest speakers. So they held it over 4 days, and there was, I don't want to give misinformation, but it was like 80 some speakers and all these
breakout
like
sessions?
45-minute sessions.
Okay.
So for me, as an independent registered nurse advocate, I take clients, they're self-pay clients, but I still need to know what the Medicare changes are because they're still going to have to go get their medications. Yeah. Right. Medicare Part B, there's big changes with Medicare Advantage, and now it's going to be open enrollment for October. So I might not now know specifics. I know who to get them to, but I also had some education on that. So I think that going to that seminar was good because it shows that you want to excel in your field and you want to network with other people doing like-minded people and build your knowledge base. And same thing with sitting for the board advocate, sitting for my boards to become board certified as a patient advocate it's saying that I take this seriously and this is my practice. And there's a code of conduct and people just aren't out there willy-nilly.
I'll tell you, you could be what would you call it? A care manager. Care managers are popping up left and right. Care managers are popping up left and right. And maybe they know how to navigate the system, but they don't have.
And there's care. I met some the other day. I met some at Byron Park too, just did. It's beautiful. Their Renaissance fair. And then I met a group there, but again, they're social workers and not to negate. Maybe they go into the home to offer some assistance. Maybe they're still communicating with family members that might not be, they're in a different state. So it's still good. I think anything, if there is a need and you still need to put eyes on mom or dad or an aunt or an uncle, if there's a need, when it comes, I think, to more healthcare, maybe medical questions, like having that, I have a master's degree in nursing. I have 20 years of experience. So it's going to be maybe not it's a higher level. Yeah. So if you need to maybe control of the situation or you really just want to, I don't know, it just depends. Like if it's multiple medications or it's maybe more of a complex situation, there are nurses out there. I would say there's definitely less nurse prepared advocates than just like healthcare advocates, but we're out there.
Yeah. And then so how do families find you? How do they engage in your services?
Sure.
Are they referral from the hospital or they just have to seek you out on their own?
So in this area, we have Bay Area Healthcare Advocates, which there's a website.com, and that will give you a list of advocates in this Northern California area. Again, not everyone is board certified. Not everyone is a nurse. So you just have to pick through because maybe there's someone that deals with insurances.
Yep.
Or there's someone that, and appeals.
Yeah.
And then there's someone that deals with, what is it? Difficult to diagnose,
Okay.
mystery illnesses.
Okay.
Again, I'm senior focused, preventative. I so much want to try to help them maintain their lifestyle. So I think it's more prevention, but there's nurses on there as well. Paige Yaya is out of Santa Rosa, and she's a board certified patient advocate and a nurse as well. And she's been doing her business for the last 3 years, and that is Streamline Advocates.
Okay.
So I would say that there are other advocate websites that they can go to as well.
And that's
GNA Now.
I only want them to find you. So
okay. And there's also GNA Now. If you're not in the Northern California or California area, GNA Now for those that would be good to find an advocate on.
Okay.
As well.
Good. Now, is there anything that an advocate won't do, or the families can just expect to just come to you and you can just assess the whole situation?
So I can't say I feel like it's not a broad topic to say like what an advocate won't do. But for me, I would say what I can do is I can have the difficult conversations.
Okay.
I can go to the office visits. I can help provide you with alternatives, or where do you go for clinical trials? For the lady one of my clients that I have, for her this Repatha drug is brand new. The doctor said, this is what I could put you on. It's going to be very expensive because it's not covered. We don't know what the side effects are. And if you have any issues, go to the emergency room.
Ooh, scary.
And so knowing that might not be the best option for her, let's look at what other options you might have. Do you want to go to functional medicine? Do you want to look at alternative? Because not everything has to be pharmacy, like big pharma and drugs, like what holistic things. And for her, that was in line with her goals and her family's goals, that I feel like this is opening a soapbox, but there's documentation that people on statins, there's a correlation to having a cardiac event. You have to provide your client with alternatives.
Yeah.
And it has to meet their goals, especially if you want them to listen. Do you know what I'm saying? Because you can't say someone is non-compliant.
Yeah.
This person isn't non-compliant if she was provided with options that were not in line with her beliefs or what have you, right? So it would be to help you navigate best options. I do things like if she needs a blood pressure cuff, I say, okay, hold on, and I'll just send her the link.
Yeah.
So you don't have to figure it out. I'll just, you purchase it, or I could purchase it for you, but this is like the best rated, lowest cost on Amazon. This is for people that if she doesn't feel well, because she had asked me, this specific client had asked me, what's the difference between you before she took me on? And if I just call the 24-hour, like nurses, there's 24-hour nurses, but it's the relationship.
Yeah.
Because if you call it a 24-hour nurse line, you're calling the advice nurse, they don't know who you are.
Yeah.
They read you have high blood pressure, and a majority of the time you're told to go to the emergency room.
Yeah.
Versus if you hear it.
Yeah.
Because I've heard somebody already that I called 911 for, and they went to the hospital with a bleeding in the brain.
Wow.
Versus somebody else who just says, you can hear it because you've heard it. I've heard it for 20 years.
They're like, Betty, I'm in you're like for 7 weeks, and there's a little slur there. What's going on?
And for this client, I was able to tell her daughter, if because of this blockage, because of some of the things, now if you hear her say anything like this, that's automatic 911.
Okay.
You're able to put in life alert. Let's put these things in place now.
Yeah.
A lot of people don't even wear those because they're like, I don't want to look old.
Yeah. They have some new modern ones that have watches and stuff.
But you have to have that conversation.
Yeah.
You have to be able to provide them with options. So going back to what I would do is it's the providing of options. It's having open conversations and hard conversations, and not being, I think it's hard to have that conversation with your mom or your dad, or you don't want to lose them. And you're like, but putting someone in place to maybe help mitigate that or have those crucial conversations. If you have any questions, please give us a call. The business is A Nurse in the Family, and you can find us on www.anurseinthefamily.net. The phone number is 925-477 7318. What else?
Perfect. Thank you for coming. Appreciate it.
Okay.